Good evening, everyone, and welcome to another session of Healthy Hints from HAM. October is Breast Cancer Awareness Month, and this evening we have a panel of experts to discuss breast cancer and answer whatever questions you might have. So if you have questions, type them in your comments section. We'll get to those. We want to welcome Dr. Deepa Halaharvi. She is a cancer surgeon specializing in breast cancer from Ohio Health. Welcome.
Thank you.
Alisa Petrella. She is the executive director at Coleman of Columbus. We have Shai McClendon, who is a survivor, and Linda Canny, who is a survivor slash host. Welcome, everyone.
Thank you.
Breast Cancer Awareness Month is a time when we all talk about breast cancer to bring awareness, although we should be talking about it every day. I can remember when I was a kid, teenager maybe, and I was walking through a room where my mom and her friend was having a conversation about one of their peers, and they were talking about her breast. But as I walked through the room with my ear up, they stopped talking. That was a long time ago when it was taboo. Nobody talked about it. That was before even mammograms, I think. But now we talk about it all the time, and we need to continue to talk about it. So we've come a long way, and we can't stop talking about breast cancer because it's very important. According to Komen, 44,000 people in the United States will die from breast cancer in 2022. And I'm assuming they said people instead of women is because men also can have breast cancer. So I'd like to start talking with Alisa. Welcome.
Thank you.
Alisa, can you tell us a little bit about some of the risks of breast cancer and who and when women should get screened?
Well, I think Dr. Halaharvi can probably speak a little bit better to the screening guidance, but I can say that, at Komen.org is a wonderful resource. So if you do have questions about when you should be getting screened, questions you should ask, you can find all of that on our website. I think that it's all about knowing your normal and knowing your family history. And that's what those resources can help you do, because that's going to have a lot to do with when you should start your screenings. Typically, I think it's sort of after your 40s into your 50s, that's the common guidance. But it really comes down to your family history and what some of your risk factors may be. So I think it's really about talking to your doctor about personally where you should be.
Okay, now, can we ask you about the pandemic and how it affected women with breast cancer?
You can, yeah. I mean, it was obviously it had a huge impact on women who had been diagnosed and had not yet been diagnosed. We saw a delay for a lot of people in getting their annual screenings. They were not going to the doctor to get those mammograms. And so we're projecting that there will be a heightened later stage diagnosis rate here in the coming years as a result of that. And so we're seeing sort of a higher urgency in needing to get patients into their doctors and their screenings done now so that we can try and avoid as much of that as possible and get them any treatment that they may need. So we've definitely seen a ripple effect from that.
Okay, now I read on your website an article that said that inequities were highlighted during the pandemic in breast cancer treatments for under-resourced communities, as well as the treatment between Black and white women. Can you expound on that?
Sure. So we know that as a national median, we see a 40% higher mortality rate with Black women versus white women, which is unacceptable. And that is a statistic that Komen has known for many years, even before the pandemic, and something that we've been trying to address with our programming in the 360-degree approach that we take. So we have direct services and programs that we're really trying to be available to under-resourced communities. We're really reaching out to make sure that they know we're here to support them them, but we also have the side of advocacy and action and doing things on the policy side to really drive change that's going to be impactful. And also in our research investments, we're really investing in this space, in clinical trials, in recruiting women of diverse backgrounds and races to be a part of these clinical trials, because that's what's going to help drive research and critical research and breakthroughs forward in a more meaningful and impactful way.
Once a year, at least before COVID, the mammography mobile would come to our church. And when we advertised it, we always said the mammograms are free if you qualify. I noticed that you guys have something called treatment and financial assistance programs.
Mm-hmm.
So if I have insurance, can I take advantage of one of those programs?
You can, yes, because the coverage, the financial assistance that we're offering is not just for mammograms. It can cover that. It can cover screening costs, but it can also cover the fact that you may have paid for a screening, or you're paying for treatment, or you're having some struggles, so you need help with childcare or the gas payments to get to treatment or to some of those screenings. Gas for your car, or maybe it's groceries that month, or your rent payments. So that financial assistance is there for a myriad of uses, whatever can help you get through what might be a financially challenging time based on the treatment and things that you're going through as a patient.
Okay. Let's go back to the other question I had. We're going to direct that question to Dr. Hala Harvey.
Yes.
Did I leave out
So,
Hala Harvey? Okay.
yeah, no, you're correct. Yeah.
Okay.
So your
What are
question
some
is
of the
when to
risks?
start. Oh, I'm sorry. Go ahead.
What was some of the risks of breast cancer, and who and when women should get screened?
Yes, the risk of breast cancer or being a woman is a risk factor. Having early periods earlier than age 13, late menopause then later than 55, and family history of breast cancer, or having a atypical biopsy in the past. That's a risk factor. Believe it or not, having dense breast tissue is a risk factor. And those women who've had mantle radiation to the chest as a result of non-Hodgkin's lymphoma, they're at risk factor for getting breast cancer. And of course, there is genetic mutations like BRCA, PTEN, CHEK2, and ATM. There's different mutations that also put women at risk for breast cancer. And I think the second question was, when should one start getting mammograms? We follow the NCCN guidelines, the National Cancer Comprehensive Network guidelines. These are the guidelines that recommend an average risk woman to start getting mammography at age 40. These are the women who are considered average risk, meaning they don't have a strong family history of breast cancer and they're not considered high risk. For those women who are considered high risk, they need to start mammograms 10 years earlier than the family member, the youngest family member who was diagnosed with cancer. And someone who's considered high risk, there are computerized models that calculate a patient's risk, and physicians can help with that. And if your risk is greater than 20% lifetime risk of developing breast cancer, you should get a mammogram as well as a breast MRI once a year. As well as, of course, doing your own monthly breast exams and seeing a physician every year over 40. If you're between 25 and 40, you can seeing a physician or a clinician every 3 years. But if you're high risk, you really need to get in to see your physician at age 25, and they will start getting your MRIs at 25 and mammograms at age 30.
Wow, that's okay. Um, what is a baseline mammogram?
So baseline mammogram is the mammogram that a woman gets the first time. Women does not have any other mammograms in the past. So that's the baseline. And so for an average risk woman, we do recommend that to start getting at age 40.
Okay.
And get it
So,
every year.
okay, thank you. Um, so I assume that, okay, so now I've been diagnosed with breast cancer, and now I come to see you because I'm probably going to
Yeah.
need surgery, right? Okay. So I come to see you, and I sit down in front of you. We talk about it. So I'm assuming, what are my options? You start telling me about what my options are. Is that correct? Would my options be
Yes.
based on the stage of breast cancer I have?
That is correct. Yes. So when you come in to see me, and so I'll pretend like you're my patient. So what I will do is I'll show your pictures, your mammograms, your ultrasound. If you have an MRI, I'll go through all that. I'll show your pathology report. We go through what is the kind of cancer, the type of cancer, the grade, the hormone receptors, what stage. And I have a little book. I show the pictures of what ducts and lobules look like, where the cancer starts. And then, of course, your options, your surgical options. Lumpectomy versus a mastectomy. Lumpectomy is just removing that part of the tumor and some little bit of normal healthy breast tissue, or a mastectomy is removing the entire breast. And it really depends on the size of the cancer. So mammograms have shown that women who have regular mammograms do get diagnosed with cancer at earlier stage, which means lesser invasive surgery. So she could have a lumpectomy, does not necessarily need to have a mastectomy. A lumpectomy with radiation, women have the same survival as a mastectomy. And I also then talk to women whether they would require chemotherapy, radiation. Sometimes women require chemotherapy before surgery, and those are a little bit sometimes advanced cancers that require chemotherapy before surgery. But I pretty much, so when a woman gets diagnosed with cancer, I consider myself the first responder or captain of the ship. So not only my job is to help them to get the cancer out, remove the cancer, but also my job is to help the whole person. I help them to navigate them to go to radiation oncologist, medical oncologist, and whoever else that they need to see. I send them to the appropriate physicians or the clinicians.
I had a question that left me. So if I don't do the mastectomy, all right, is there a chance that it might come back?
No. So the when a woman has a lumpectomy with radiation versus a mastectomy, the survival is the same, meaning they will live the same time. They don't die sooner because you had a lumpectomy and not a mastectomy. What is true is if you have a lumpectomy, your risk of cancer coming back, assuming you got radiation and you're taking anti-estrogen medication and all the other things, risk is about 7% in 10 years. After a mastectomy, the risk of cancer coming back, you could still have cancer on the chest wall, is just important. Not, you just cannot remove every single cell of the breast tissue. So there's still a chance of cancer happening on your chest wall after a mastectomy, and the risk of that is up 2 to 3%. So it's really not that much difference between 3% versus 7%, statistically speaking. So that's why we say survival is the same for women who has a lumpectomy with radiation or a mastectomy.
So, do you recommend when you have the breast cancer, you only have it on one side, do you recommend a mastectomy for both breasts?
Yeah, that's a great question. So women ask me this all the time. Typically, if a woman does not have a genetic mutation, the risk of having cancer on the opposite side is 0.5 to 1% per year. So that's 5 to 10% per 10 years. So the risk of developing cancer on the side is not very high if you don't have a genetic mutation. Now, if you have a BRCA mutation, then the risk of developing cancer on the other side is much higher. We do then recommend a surgery on the other side. I mean, they still don't have to. We can still follow them with the mammogram and MRI, but the risk of developing cancer is high. So there is no survival benefit, meaning women, again, don't live longer by removing the normal breast. Sometimes women will opt for a mastectomy on the other side for symmetry purposes. They don't ever want to get a mammogram, things like that. But our job is to educate them that there is no survival benefit of getting a mastectomy on the other side. But you know what? It's a shared decision making, meaning we have to take into account what the patient wants, and we sit down and we talk about it. And ultimately, whatever the patient wants, as long as they understand all the implications.
Okay, that's good. Our survivors here, we have Shy. Shy is a survivor who contracted cancer at an early age. Shy, do you want to tell us your story? Because I'm going to be going back and forth here.
Yes, certainly, Ella. So, I am actually a two-time survivor, and I was first diagnosed when I was 32. Um, it was stage two, based on the actual size of the tumor, which was about a quarter size. I had chemo first, followed by surgery, and then radiation. I was in remission for 7 years when it did come back. I had been doing all of my routine medical visits and mammograms and everything like that. So when it was found the second time around, it was only calcifications. I was how was it 39 at that time, so it was about 7 years in between um, cancers. So this one was a little bit more aggressive. It was diagnosed. I was diagnosed with as HER2 positive. Again, the first time I had a lumpectomy. The second time I did have a mastectomy bilaterally. The cancer came back and it was right almost on top of where the first cancer was at. So there was definitely no keeping of the left breast, but decided to go ahead and have the right breast removed at the same time. And as Dr. Holivar had stated, it was more of about being having the symmetry. And I had again, I had what did I have? I had the chemo first, and then I had surgery, and I had immediate reconstruction at the same time. So um, as I woke up, I just felt that for myself that I need to feel like I still had breasts, so I wanted that reconstruction right at the same time. So,
Okay,
and
so the
so that
first
would be my
time
story.
you were 32
Hmm.
years old. How did you discover it? Because that was before the time to get a mammogram. So how did you discover that you had breast cancer?
Yes, actually, my gynecologist actually found it while I had been doing all of my preventative measures and doing my self tests. I just thought it felt like fatty tissue. So, on my annual exam, he found it. It was, you could see it, it was a touch thing where you could feel it, but you couldn't see it on just a regular x-ray. So I ended up having to go have an ultrasound done. And then from there, it was actually having the biopsy done and then getting the results from my doctor and going through and then finding my medical oncologist and my surgical oncologist and so forth. So fun times. It was a
Okay,
very nice 6 months worth of time span from start to finish.
right. Okay, and now Linda, on the other hand, is a survivor. And Linda, tell us how you found yours.
Well, like Shy, I'm a two-time survivor as well. But I was also getting my regular mammograms because I did have or do have a family history of breast cancer. My mother and one sister both had breast cancer. So I was very, very diligent about getting regular mammograms and about doing self breast exams. So I had just had a mammogram about 3 months prior to my discovering a lump when I was doing self breast exam. And it was kind of so far around, almost under my armpit, that it wasn't detected on a mammogram, so it was missed. So I found mine, which really speaks to the importance and the diligence of doing self breast exams. Because had I not been doing those, then I would have, it would, who knows what could have happened, and I wouldn't have been scheduled for another mammography for another year or, however long. So that was the first time. And then 23 years later, it came back in the same breast, um, almost in the same location, but not quite. And this time it wasn't as, the first time it was, I think, 3 centimeters. This time it was somewhat smaller. So the first time I had radiation, I had chemo and radiation after having a lumpectomy. And this time I had a lumpectomy and just radiation, but twice a day. I had to do radiation twice a day because I had had radiation in that same breast. And they felt that they needed to divide the dosage because of that, because it had been radiated previously. Even though it had been 23 years ago, it still had been radiated. So that was what I was advised to do.
And I think I had my two survivors here to show that um, at an earlier age than 40, before you start getting a mammogram, you can still, have breast cancer. And then at a later age, when you start getting your mammograms, we've got two people here who Linda found her mammogram through self-examination. And Shai found her, I mean, your lump
The
through
breast cancer.
self-examination. Mhm. And then Shai found hers the first time via doctor examination. Is that right? Right. Okay. So I guess I was just trying to show how it's important to do your own self-examinations, to be diligent about that, which, I sit here and I talk about it and I really don't do it all the time. So shame on me. Um, and then again, to be diligent about getting your mammograms. And I think, am I saying that right? Because mammography is the actual science and the mammogram is the actual picture. Is that right? Okay,
That
but
is
we find
correct.
ourselves
Yeah.
mammogram. So I always say a mammogram. So the picture, the actual picture.
Yeah.
I have a couple of more questions, but uh, what is a DCIS, Dr. Halavari?
Yes.
Halavari.
Before I answer the question, I also wanted to say I'm also a breast cancer survivor. I don't know if you knew that or not. I
I
was
did know that. I'm going to get to you. Go ahead.
Yeah, yeah. So I was diagnosed on a mammogram, so a screening mammogram. But I completely 100% agree with you that breast exams are very, very vital. It doesn't matter how old you are. We need to start teaching our kids much younger to examine themselves and talk about breast exam. And yeah, thank you for saying that. And then DCIS or ductal carcinoma in situ. What that is in the breast there are ducts and lobules. So if you imagine grapes, the stems, the grapes are the lobules, the stems are the ducts. So the cancer that forms inside the ducts is called ductal carcinoma. So if it remains inside the duct, it's called ductal carcinoma in situ. If it comes outside the ducts, that's called invasive ductal carcinoma. So DCIS is a stage 0 breast cancer. Typically, women don't need chemotherapy. They do need surgery, whether it's lumpectomy or mastectomy, really based on the size and the amount of DCIS a person has. And then they may require radiation after that, depending on if they have a lumpectomy versus a mastectomy.
Okay.
And I had
Let's go
the
back to
DCIS. Sorry, I just wanted to add that I had the DCIS. So that's why my protocol called for radiation.
Okay.
I
okay.
had that also.
Oh, okay.
That's
The
the second
first
time.
I
The
time, and
second
then
time.
it
In my
was
case, the
HER2
second time. That's what I
positive.
had.
Yeah,
Yes.
that's what you had the second time.
somebody gave me that question and I didn't know what it was, so I looked it up. I'm like, oh, okay, that's what that is. But now I've got two people here, and they both had it. Okay. I guess when I looked it up, though, it didn't say it was rare. So I want to ask Elisa some more about Komen. We do the
Sure.
race for the cure. We do the race for the cure. That's all over the country, and the race. I'm assuming that a lot of that um, money, for lack of a better term right now, that you get is used for research. Is that correct?
Yes, research, but also the programs that I referenced earlier, which are serving patients and their families now. So we sort of split the money a little bit between those couple of parts of our mission, so that is serving families today, but also working on those breakthroughs for tomorrow.
Okay. I should have said funds, not money.
Okay.
Okay. Um, there was one other thing here that I wanted to talk about. Uh, there's been a study conducted by the American College of Radiology and a few other people that talked about the use of mammography screening only being 85.3% utilized. That was before the pandemic. And now, since we've had COVID, they're saying that they need, I don't want to say that, They need these patients, the providers, they need the patients to feel safe. I'm paraphrasing. They need the patients to feel safe when they come in for their mammograms. So, does anybody know what is being done to make our patients feel like they're safe from COVID when they come in to get a mammogram?
Yeah, I mean, I can answer that question. I think since the COVID pandemic, they clean instruments, so the mammography machines are cleaned, and of course, patients get like the wipes to clean themselves. And I mean, washing hands is very much emphasized at our institution at Ohio Health. We are still using masks, so we still are mandated to wear masks. So patients also have to wear masks. So I mean, we're taking, of course, a lot more precautions than we did pre-COVID. The numbers are getting better, and I think you're right. Patients do need to know that it's safe to get back to their institution to start getting their mammograms because missing a mammogram can be costly. The cancer can grow, and women may need additional therapies, invasive therapies, and extensive surgery, and of course chemotherapy, so on and so forth. So it is safe to get out and get a mammogram. So.
Did you have any questions you wanted to ask, Linda?
Yes, I do. In the last few months, I've been hearing more and more about women with dense breasts, and particularly now, I've been hearing a lot during Breast Cancer Awareness Month about the incidence of women with dense breasts and what that actually means, and what questions we need to be asking our health providers, because that isn't something that is automatically, in all cases, shared with women. And if it is shared, what does that mean in terms of getting your mammograms?
Yes,
So
it's a very good question. Yeah, very good question. So dense breasts basically means your breasts they look white on a mammogram. Your cancer looks white on a mammogram. So finding a cancer is like finding a snowball in a snowstorm. That's kind of how I describe it, or snowflake in a snowstorm. And it's really hard to find that. So having dense breasts itself can increase the woman's likelihood of developing cancer. So almost all states are mandated to give women the type of density that they have. Or do they have extremely dense breast tissue, heterogeneously dense, moderately, scatteredly dense, and fatty tissue, or like the 4 different criteria for dense breast tissue? And the mammographers are supposed to tell them where they fall into that. And if women have really dense breast tissue, there is a law that's been passed most recently that actually mandates insurance companies to pay for additional screening with a screening ultrasound. Or at Ohio Health, we actually happen to have abbreviated MRI, and that's very similar to traditional MRIs. It's only that it takes less time, and it's very, very inexpensive, $300 or so. So even if the insurance didn't pay for it, you could pay for it. So why do we need those additional screening? So mammogram is still recommended for dense breast women, but it can miss cancers from these dense breast women. So we need to add additional modality like a screening ultrasound or a MRI. And if your institution has a contrast enhanced mammography, that's another thing that you can ask for. But screening ultrasound and an abbreviated MRI are really perfect for those women with dense breast tissue. If you have that on uh, on a mammogram, where you get your results that says you're extremely dense breast tissue, you want to ask your physicians to order other testing, whether it's ultrasound or MRI or contrast enhanced mammography, something to make sure that we are not missing anything in those dense breast tissue. You have to be your own advocate for sure. Yeah.
absolutely. So demographically speaking, are Black women more prone to have dense breasts than other women, than white women? Do you know,
I
statistically
don't.
speaking?
I mean, yeah. I mean, I haven't really seen where Black women have a more dense breast tissue. What I do know is breast cancer in African Americans can be pretty aggressive. It can be diagnosed very young age, and unfortunately, we don't recommend screening mammograms till age 40 for this average risk woman. But 85% of the time, women who get diagnosed with breast cancer don't have a family history of breast cancer. And so if you wait and you're not doing your breast exams, wait till 40, sometimes it can be too late. So again, I think going back to the importance of doing your own breast exams is so important, especially in the African American community. That's one of my passions. I talk about this. I've done Ohio Health Cancer Prevention Wellness series where I talk about increased mortality in African American women from breast cancer, delayed diagnosis, late stage diagnosis, and really not good follow up with the physicians just because they don't have haven't had great experience in the past with the physicians, and which leads to increased mortality. And so there's a number of issues. But you really have to be your own advocate. We have to talk to each other. We have to tell each other the importance of breast exams as well as mammograms.
Yeah, I find too that talking to particularly young women in my family, they because we have breast cancer on my husband's side and my side of the family. So in talking to my nieces, I have two nieces whose mother and aunt both have breast cancer. And talking to them about getting mammograms is like whistling in the wind. I just cannot get them to see the importance of it at the age that they are. They are all, well, one just turned 50, the other one is a little bit younger. But it's one of those things that does not seem to be a priority, even with it, so rampant in our family. Any words of, encouragement or how to impress upon them the importance of early detection? I mean, the numbers speak for themselves, but any ideas of, how to encourage them to do, even if they do just self breast exams? You've made
Yeah.
a point about really knowing your body, which is really important.
It's very important to be aware of your body. And I think maybe they need to see a clinician who can then show them how to do a breast exam. I'm actually very active on social media. I post a number of videos and do vlogs and Instagram posts. And just this month, I've been posting something every day and just, talking about how to do a breast exam, why you should do a breast exam, the dense breast tissue, all those things. So I would say, just talking to them about the importance of it, and maybe sometimes the young kids, they feel shy to talk to their own family members. Maybe seeing a clinician, that may be better. Than they're not as shy, maybe talk to an outside person who is actually does this on a daily basis and shows them how to do an exam. And I think, speaking of knowing your body, it's not just breast. I think it's everything. We need to know, is there any change in bowel movements? Are you losing weight? Are you gaining weight? Is there any other stuff going on with you? I think it's just very important to know that, because I'm also seeing colon cancer in young people too, so it's really important to know yourself. And I think we need to start teaching our kids from the young age. I think we didn't grow up like knowing all these things, but we need to change the conversation and, with our kids, telling them the importance of, taking care of themselves.
Thank you. I see a question here about what is the relationship between age and dense breast tissue?
Yeah. So as we get older, so young women, we have dense breast tissue, just a lot of tissue that just feels very hard. But as we get older, it becomes replaced with fat. So it becomes more fatty, meaning it's less dense. It's easier to detect cancer as we get older, especially after we go through menopause. Hope that helps.
So I have another question about dense breasts too, and maybe this is for Komen, but in terms of insurance for covering that extra step, if or when women are aware that they have dense breasts, does Ohio, most insurance companies in Ohio, cover that additional testing, whether it's the MRI or ultrasound? Would Komen, some of the funds raised by Komen, would that help to cover insurance?
Sure. So I know in Ohio, we have a much stronger policy than other states and other parts of the country in covering those secondary screening and diagnostic visits. But it's not necessarily a blanket option. So it's definitely checking with your insurance company and seeing if that's available. But if you're not getting the help, or even with insurance, if that cost is still higher than you are comfortable covering, you can call Komen and we will help you with those costs. Yes. It's all through our
so if
helpline.
someone has even the Affordable Care Act as opposed to, private pay, do you think it's most insurance, the Affordable Care Act would cover insurance for that extra step?
I'm not familiar enough with Affordable Care Act just in my role, so I don't want to advise on that. But I will say that you again can access the funds. Ohio also has the breast cancer and cervical program that you can call. It's a state program, and Komen navigators and our helpline can help you access the project as well, so that if you are eligible, then the state of Ohio has funds available to help cover those costs too. So what Komen is doing is we have that financial assistance if some of these other programs and resources are exhausted or are not available to you. And so we're trying to sort of fill some of those gaps as well. But what we're going to do is exhaust every resource available to you. So looking at your insurance, helping you call and navigate your insurance, but also saying, okay, so your insurance isn't covering this. Let's see if you're eligible for the breast cancer and cervical cancer project, or BCCP, and I feel like I'm mixing up my words a little bit right now. BCCP is the program, or do we need to now advance you into Komen's assistance program and get you the funding to make sure that you're getting the health care you need?
Great. Thank you for that. I see a statement as well as a question in the chat. The person says they were in sticker shock with my insurance company after advocating for an ultrasound. And then the question is, how can we best advocate for better coverage on the front end with insurance companies so problems can be spotted? Anyone want to speak to that?
So we do have a law that's been signed by the governor for the dense breast tissue or dense breast patients, where it is going to be mandating the insurance companies to cover the additional screening modalities. I mean, I know the problem is I don't know with the different, insurance coverages, like the Affordable Care Act probably doesn't cover the, commercial insurance companies do. And so, with everything, it takes time. So right now, I mean, there was a time where we did not even know women were not even told they have dense breast tissue. So we're doing better. We are telling women that, okay, now you have dense breast tissue. Now we're taking a step further and saying, okay, you do have dense breast tissue. Now, these are the other modalities of imaging you can get, whether it's ultrasound or MRI. And now we're taking another step, with this law that's recently passed, is making the insurance companies pay for it. But, all of that takes time. This just happened this last month, so it's going to take some time for insurance companies to get familiar with it. But there will come a time, hopefully, for a future generation, that it's going to be way better than it has been for our generation. So that's my hope and prayer.
I can jump in just quickly too with Komen. One of our main pillars of work is advocacy. So if you are interested in, that was your experience and you want to change what's happening next, we have advocates. You can volunteer. We sort of have programs where we talk about what we're trying to do either locally in your state, in your city, but also federally, so that some of those issues can be addressed. And what we need are a lot of voices, and your voices and experiences and stories to help move those types of opportunities forward. So just so you know, Komen.org, you can look at some of our advocacy efforts too.
Great, thank you.
There's one more there.
Mm-hmm. What is the biggest myth or misconception about breast cancer? From your experience.
There are a lot of myths. Yeah, there are a lot of myths that I see. One is, if I don't have family history, I'm not going to get breast cancer. I think that is the biggest. The other one is, when I have pain, I must have breast cancer. pain 95% of the time, and you must absolutely still see your doctor, but 95% of the time when women have pain, it's not breast cancer. So about 5% of the breast cancer is associated with pain. Deodorants cause breast cancer, and there is really no research to really prove that. We don't have randomized control studies. I think it's very hard to get those. Do underwire bras cause breast cancer? No, I think underwire bras can be comfortable, can cause some chest wall pain, tenderness, costochondritis. I see that a lot with underwire bras, but they don't cause breast cancer. The other misconception is men don't get breast cancer. Well, we diagnose about 2,500 men every year with breast cancer. So not only for women, even men need to be familiar with their body and making sure that they're checking men. I have, a few men that are, breast cancer survivors. So those are the top few I can think of top of my head. So,
Shai, did you have any questions?
Can never
We don't
find
hear
that mute
you.
button. No, I don't.
Okay.
That's because I can never find the mute button, but no, I don't.
Alisa, is there something else you'd like us to know about Komen and what's going on there?
I think that I was able to speak with your congregation last year too, but we're really moving forward in some of our health equity work. We have the Stand for Her, a health equity revolution initiative that is now a global movement for Komen. It had started as sort of us benchmarking and piloting some programs in some specific cities, but it's now really the center point of what we are doing in our services and research and all of our work. So I just want to say thank you for support and everything that the community has done to help Komen continue to serve you really and invest in these programs that are going to make such an important impact.
Dr. Hala Harvey, is there something you'd like to leave us with?
yeah, I mean, what we've already talked about, just be your own advocate. Make sure you're doing your breast exam. It doesn't matter how old you are. I would recommend women starting at age 18 to have the self-breast awareness, know what to look for. And I usually tell women once a month, if you're premenopausal, check your breast a week after your period. So how you want to do it is with your arms up. You're looking in the mirror. You're looking for anything that's pulling or tugging or redness in the breast. And main reason you're looking in the mirror is because you can't see underneath the breast laying down. So mirror helps. If there's any pulling in the nipple or the skin or any changes, what we call port-orange or orange peel appearance of the breast, you want your doctor to know. Then you want to lay down and you want to use 3 pats of your fingers and you kind of go in a circle on your chest and you want to cover all of the breast and the end, squeeze the nipple, and also don't forget to check underneath the arms and also in the lymph nodes, underneath the collarbone. That you want to do once a month, a week after periods. If you're premenopausal, because your breasts change a lot before periods. If you're postmenopausal, you want to do it the same once a month, but the same time every month. And of course, mammograms, I can't stress enough about mammograms. You start at age 40 if you're average risk. If you have family history, you start 10 years sooner than your family member. That's really important. And just be your own advocate. Breast cancer is the most common cancer. 280,000 men and women will get diagnosed with breast cancer this year. And it is the most common cause of, second most common cause of death after lung cancer. So we have to be our own advocates. We have to take care of ourselves. We want to teach our young girls to take care of themselves as well.
I do have
Thank you so much.
one more question, if I might. Shai and I both had reoccurrence. So are you seeing more incidences of reoccurrence of breast cancer? Shai's was 7 years, mine was 23, but the fact that it came back. So are you seeing a higher rate of reoccurrences in women?
The times that I do see higher rate of reoccurrences is if someone has had a genetic mutation is typically, so then I would ask guys, do you have your genetics tested and did you guys have genetic mutation? But typically not more than normal. I think what's going to happen, the impact of pandemic, we're going to find a lot more advanced cancer as the years go by. We haven't quite seen that yet. As you've heard, Katie Couric, she put off her mammogram, for 6 months or something like that. And she also had dense breast tissue. So she got a screening ultrasound as well as a mammogram, and she was diagnosed with early stage cancer. I'm afraid as the time goes on, people who are afraid to go out and get their mammograms are going to be diagnosed with more advanced cancer, and their survival is not going to be as great as someone who gets diagnosed with cancer in early stages. So to answer your question, I really haven't seen increased incidence of recurrent cancer.
Thank you. And thank you for all of your information and your advocacy and your words of inspiring all of us to make sure that we're diligent with the self-breast exam and following up on our appointments.
Yes, thank you so
Thank all
much
my
for having
guests.
me here.
Thank you for being with us tonight. I hope someone got something, a light bulb moment, or found something in this conversation that helped them out a lot. Thank you all for joining us, and we'll see you next month.
Thanks.
Thank you.